Hello, my name is Maureen McBeth. I'm a physical therapist in Columbia, Maryland, and I'd like to thank ImpediMed for this opportunity to help wrap up their webinar series, Health is Fluid. My title is really derived from my thought process of how I've integrated SOZO into my clinical practice in a private practice outpatient setting to guide targeted treatment strategies. Just a little note, I've turned the camera off so it doesn't obscure some of the data on my slides. But with that, getting back to this motivating question that I have, with my clinic owner manager, I said, SOZO is really the heart. It's how I'm going to get people into the clinic with the data that SOZO gives, with being able to use it for marketing. It's integrated my model of care because I've been a champion of prospective surveillance. And I'm also able to get these data points every time they're in because it's so quick. It takes 30 seconds for me to get all this wonderful data. So I couldn't have been more excited when the APTA published their clinical practice guidelines from the Academy of Oncological Physical Therapy in terms of interventions for breast cancer-related lymphedema. And, using BIS as some of the strongest evidence-based practice that we have at this time is, in my estimation, one of the most critical things any program can do right now that is looking at doing prospective surveillance. The historical bedrock of these clinical practice guidelines really reaches back to articles such as the one by Dr. Julie Silver, who's still at the forefront of pushing the cancer prehab model. And you can see by the underlying things, these are all the things that we're all striving to do. Find out what's happening now. Almost look into the future. Improve outcomes so patients have better lives and decrease cost. And so one of the big benefits I see of having SOZO and with LDEX in my prospective surveillance model is, as I'm able to drive physical activity at all the different points in time in someone's continuum of care, I actually have data. I can show, and I'll have some case studies later on that show how I'm able to really see what's happening with someone's skeletal muscle mass or their fat mass. And during these surveillance times, be able to give them data not just about lymphedema, because remember, this is not all they're dealing with. We know patients diagnosed with breast cancer face a whole host of different issues aside from lymphedema. And we can't forget studies such as Aygan et al. This was done in Turkey, where they had fairly high numbers of women, 1 out of 5, who already had subclinical lymphedema at time of diagnosis based on the status of their cancer, obviously more disease. And in the States, Dr. Sheila Ridner had similar data where about 8% of women had some type of LDEX score that was outside the normal range at the time of diagnosis. New research has emerged again this year discussing the issue of BMI connected to severity of breast cancer-related lymphedema. And for me, again, looking back at my database that I had, I saw women who had normal BMIs but very elevated body fat that potentially could have also fallen into this category where their lymphedema could have been worse. So it's no surprise that this economic data is just staggering to think that it's $23,000 more cost if a woman with breast cancer also has chronic lymphedema, that women face 112% higher out-of-pocket cost, and or the difference between doing prospective surveillance versus just standard of care. This is a simpler model I show that just the cost of here subclinical with easy off-the-shelf sleeve and glove versus early stage where we have to get night garments involved and bandaging material, late stage where they need full bore CDT, custom sleeves, gloves, night garments. Doing the math is not hard. What is hard is to look at these barriers of care that have been identified as far back as this amazing pulling through study from the Cancer Journal in 2012. And I've highlighted some of the main areas: our fractured delivery of healthcare, the lack of established relationships between the oncologic specialist and rehab professionals, patients who expect to have these problems and feel they just simply need to be tolerated, and then that general lack of understanding of the role of rehab and how we can actually work with a lot of these physical impairments. And then finally, the infrequent referrals, the lack of collaboration to our services. And so in the next couple of slides, I'm going to go through and show you how I've actually used these barriers of care to create my marketing plan and help break these down. And by using SOZO as the heart of my program, patients actually can grow their knowledge. They can see data to help them play a more active role in their decisions and then have awareness in their choice. And I'm not kidding when I tell you, my patients come in and they barely say hello to me. They're like, I've got my shoes off, I'm ready to get on SOZO. And I'm like, all right, I've done my job right. So in light of that, I want to highlight how important it's been to have SOZO through the pandemic. I really thought our whole practice was just going to implode. And conversely, patients said to me, I feel like I'm really getting something when I come in to see you. You're giving me things to do on my own, but I can check in with SOZO on my LDEC scores. And so that is really what happened. And a lot of the data you'll see in some case studies coming up is that I was able to help patients get through this. And that has been so exciting to me. Getting back to this whole concept of being able to do body composition with SOZO, this is one of the most important things that Dr. Ward even highlighted in one of the earlier webinars, is we can't just look at the packaging and know what's in it. BMI does not always tell us what we really think we know. So this was a picture, actually that's me on the left with my fireplug body type compared to one of my patients, and we're both 31% body fat. I've always felt the body composition was important to know at our baseline pre-op consultations because it can help me target where I have to do strength training with a particular patient, or do they have other issues with balance and gait? Do they already have lymphatic issues? Do they have other swelling problems? We actually screen for lower extremity swelling on our patients. So all of my patients not only get that information that's very important for shared decision making, but they get post-op exercises, be it range of motion depending on their surgery, or it could be strength training. If they're, let's say, just going for chemo first, they get functional activity guidelines, at least a walking program, and written instruction educational materials, plus knowing when to come back for surveillance. The early webinar that Kate Perkins did talked about this specifically, and how I've talked about really, both the referral pathway and that educational piece has been so critically important. And that baseline pre-op opportunity for education really hands patients back some control. And one of the newer things I've instituted is having every patient leave with a copy of the ACMS guidelines for physical activity in people with cancer. My patients also get a very quick rundown of the importance of cell health and water in their body, so they have a better chance through their entire treatment continuum of not having some of the bad side effects. We even quickly get into cell biology, and depending on the patient questions, I go even deeper into this, but they start to understand that we're talking about a lot of cells in the body. And in reality, do you want your cells to be like raisins or like grapes? So you can see how I get back to my motivating questions and why I was able to say to my clinic manager owner that I need SOZO in order to function. I really cannot do my job anymore without this. So the whole concept of SOZO and of that targeted treatment is woven through everything we do in our organization, even in our marketing materials. SOZO really helps me get my patients to commit to the long haul. And this is a brief case study of a patient who I saw at my prior facility at a hospital, and she decided to follow me to my private practice because I had SOZO. And we were able to get all of this rich data as her lymphedema was progressing, and she was looking at more surgery because she had to have her implant exchanged due to some of the secondary cancers that were potentially developing from the textured implants, and her ongoing lymphedema. Now, this was a patient who never had a big interlimb arm volume, but we could always see the fluid in her arm, and SOZO always picked it up very well. And you see post-op, she had some swelling after we adjusted her garments over the long haul, the course of 2018 through 2019, and now into 2020. She has very well managed lymphedema. And, hopefully I'll be seeing this patient for as long as she lives in the area or that I'm in the area. She'll be my patient for life, really. This second case study is a quick snapshot in how we can still use SOZO even after surgery. So this patient had a neglected breast cancer, and even though we didn't see her until after the surgery and she needed more surgery, we were able to get the arm under control prior to that second surgery. But my favorite type of case study is the true prospective surveillance model. And this was from a man who had melanoma and had to undergo complete axillary dissection. This was a true pre-op baseline. We caught post-operatively when he started to have cording. We caught when he was having a seroma. And we also were able to intervene when a chest wall cellulitis came up when he started immunotherapy treatment and get it back under control. So by later that winter, when he went on his yearly vacation, and he was a very avid windsurfer, he was able to get back into that level of activity. I've included this case study of a patient who just recently passed away, but I saw for almost 2 years. He originally came in with very advanced genital lymphedema, and really it was most likely part of his whole recurrence of an ongoing 2 different tumors that he had. And we were able to really highlight this point in time right here that I'm going to circle, where his LDAX not only goes through the roof, but he has this massive shift in total body water. And when initially I said everyone, that was really his doctor and the nurses at the hospital, kept telling him, oh, you're doing great, your weight's so stable. And I was able to show them this data that really helped change their understanding that maybe he wasn't doing as well as they thought. And so they were able to identify a recurrence and start him on some other treatment. He had further surgery. And what we really did for him was keep him going with the monitoring. And he just felt so much better driving up to see me. And you can see all those data points. Now, I don't have the data after January, but I had some data through COVID and even until 6 weeks before he died, when he still was independent enough to drive to my clinic. So this was, in my estimation, in his estimation, and even his family's estimation, a great benefit to him to help guide his care and his function and keep him as active as possible, despite the fact that, we knew that the cancer was progressing. This next case study involves really looking at a patient who had long-term chronic lymphedema, still has a fluid component to it. You can see her high LDAX score. And we really wondered if her losing weight before her delayed reconstruction would help. So right here, what we have, I'll highlight this, is we have sort of this 6-month period that I'm going to show you, that even when her weight was higher, her LDAX score wasn't all that bad. And even when she lost weight, it went back up, although it did recover well after the surgery. In this slide, I've superimposed skeletal muscle mass and BMI because, yeah, it's great that we see the patient lose, so much weight. She's lost 21 pounds here. And you've seen this big dip in her BMI, which, that goes down, that arrow. What I'm really looking for, and it's so critical, is right here that I really want to see, some stability here with their skeletal muscle mass and make sure they're preserving that as they're losing weight. So while everyone was excited that her BMI dropped so much, and that's often what, we look at, I was very excited to actually be able to show her and her physician that she lost this 16.9 pounds of fat mass. And so again, you see the BMI drop down here, and you see this incredible decrease in fat mass. And on the previous slide, remember, I showed you she maintained her skeletal muscle mass. So at the end of the day, I find the SOZO body composition data can really not only motivate patients, but also make sure that the whole medical team sees that we're doing things the right way. So if we send patient to go lose, body fat and all she's doing is losing skeletal muscle mass, we have to change her program. We don't want to see that. So this was an otherwise very healthy patient, and now she feels better than she has and is in better shape than before she had breast cancer. So I want to wrap up with one final case study, and this is where this gets personal. This is a case involving my mother-in-law, and she was misdiagnosed with a cancer that they thought was a breast cancer. Turned out it wasn't. And by the time she and my father-in-law called to say, hey, we're having an issue, she had already had some surgery. Well, when we found out it was not making sense, she came all the way up to Baltimore to see a colleague from my former hospital, who's a very good surgical oncologist, and immediately realized there was a problem. And she was able to get a proper diagnosis of the cancer. It was a very aggressive eccrine cancer. She needed a full excision of her axilla, all the skin, and all of her axillary lymph nodes, and was then going to have radiation. So my initial reading here, I didn't highlight as a true baseline because she had already had some surgery done. But we were able to capture some data before she had the surgical intervention. And since they lived in rural Virginia and they had to drive up I-95 to see the surgeon all the time, she would stop at my clinic, and my colleague started treating her at the time. And we have, interspersed data, but we could easily see when she started to hit, one of these high points here, and we needed to get some more treatment involved. That was shortly after radiation. And, you can see we get her down, she kind of goes back up, she kind of comes back down. And what I really wanted to find out was, what was going on? Was her weight affecting this? Was there anything else going on? So we love to superimpose our little curves. Hopefully we'll have some software that will do that someday because it's fun for data geeks like myself. So here we just took her weight and tracked it over top of the LDEX scores, and we kind of see like this little curve that sort of matches here. But then she also started to report some other issues. She had a problem with some swelling in her legs. We ended up diagnosing her with lipedema, but she also has perhaps some venous problems because one leg's larger than the other. And here we started to look at some of her extracellular fluid as opposed to her total body water. So seeing some really big shifts here with this. And that led us to, more questioning and getting her primary care involved just with some fluid issues that she appeared to be having. So when we then superimposed her fat mass percentages and skeletal muscle mass percentages over time, the really great findings at the end of the day were, from the beginning of her cancer treatment down here, her skeletal muscle mass ultimately went up to here. And conversely, her fat mass, which really started up here, went back down to here. So it's kind of like a happy point there for her. And in the end, at this point, not only did she get her proper cancer diagnosis, but she has a tool that even, with relatively few visits to our clinic, she's able to get this monitoring that's really helped her enact some changes. And she's doing, you can see this is her LDEX data. She's doing a great job really getting it down here. And at the end of the day, look at what she's done with her fat mass has decreased by 5%. Her skeletal muscle mass is almost getting over that threshold where I'd like it to be above 25%. And even though her weight is, roughly the same, her phase angle has also gone up to now about a 4.5, and she was down at a 3.8, which means her cells weren't quite as happy back when she had a aggressive cancer in her body. So she's made wonderful lifestyle changes, and she just feels so confident that even with these intermittent surveillance visits to our clinic, she's able to get the quality care to help her with that shared decision making, and is an absolute fan of SOZO and her LDACs, and she has the physician champion behind it. And this is really what we're trying to get going throughout all of cancer rehab. So with that, I'd like to just thank ImpediMed again for this incredible opportunity to share with you what I've done in my clinic, and we're going to open it up to questions.